بسم الله الرحمن الرحيم. أهلا بكم في IO مصر ومن خارج مصر، من الدول العربية والإفريقية المختلفة، من أكبر الدكاترة والأساتذة. بسم الله الرحمن الرحيم. أهلا بكم في IODYC International Online Dental Use Congress في نسخته الأولى من اتحاد الجمعيات العلمية لطب الأسنان وحديث التخرج EADS Egyptian Association of Dental Students، وهو الجهة العلمية الوحيدة الموثقة في مصر والتابعة للاتحاد العالمي فيما يخص الطلاب وحديث التخرج داخل الجامعات المصرية. ويتضمن المؤتمر أكثر من 100 دكتور من مصر ومن خارج مصر، من الدول العربية والإفريقية المختلفة، من أكبر الدكاترة والأساتذة الكبار المتواجدين. وسوف تحصل على شهادات معتمدة بعد حضورك نسبة الحضور المطلوبة للمؤتمر، وهناك سحوبات يومية تصل قيمتها المالية إلى 4000 جنيها مصريا يوميا، وإجمالي السحوبات في المؤتمر تصل إلى 50,000 جنيها مصريا. ونعلن عن الشراكة بيننا وبين دول لبنان، فلسطين، السودان، رواندا، قطر، السعودية، تونس، المغرب وتنزانيا. ونتشرف بالإعلان عن البورد الرسمي للمؤتمر من رئيس المؤتمر الأستاذ الدكتور عبد الفتاح صدقة، الرئيس الشرفي للمؤتمر الدكتور حاتم الجندي، السكرتير العام للمؤتمر الأستاذ الدكتور هالة هزاع، اللجنة العلمية للمؤتمر الأستاذ الدكتور علياء محروس، المشرف الأكاديمي الأستاذ الدكتور جيلان الجندي، والضيف الشرفي للمؤتمر الأستاذ الدكتور شازع حماد. وأهلا بكم في IODYC الخاص ب EADS.
بسم الله الرحمن الرحيم. كل سنة وحضراتكم طيبين. الحقيقة المناسبة الطيبة دي بانعقاد أول نسخة من مؤتمر أونلاين للجمعية المصرية لطلاب طب الأسنان، اللي هي منبثقة أو عضو في الانترناشونال اسوسيشن، وده شيء جميل جدا. الجمعية عقدت قبل كده أكثر من 22 مؤتمر فيس تو فيس ولقاءات أخرى أقل من المؤتمرات الكبيرة كثيرة، يمكن 370 لقاء. لكن النهارده ده احنا مع النسخة الأولى من أول مؤتمر أونلاين للجمعية. المؤتمر ده بيخدم القطاع العريض من طلاب طب الأسنان وخريجي طب الأسنان، يحتوي على محاضرات في جميع المستويات لأكثر من 100 محاضر. عندنا لايف شوز وكلينيكال كيسز كتيرة، في مسابقات وفي سحب وحاجات من كل الزملاء اللي ولادنا يحبوه.
مساء الخير، أنا دكتورة عليا محروس، أستاذ مساعد التركيبات الثابتة، كلية طب أسنان جامعة الفيوم. أتشرف النهاردة بوجودي معاكم كواحد من أعضاء الفريق اللي ساعد في التجهيز لواحد من أكبر وأهم المؤتمرات العلمية المقامة أونلاين في 2022. مؤتمر مختلف جدا الحقيقة ومتميز جدا، بيظهر لأول مرة في نسخته الرسمية الدولية الأولى، نسخة أونلاين بيقدمها وينظمها اتحاد الجمعيات العلمية لطلاب طب الأسنان وحديث التخرج في جمهورية مصر العربية EADS. مؤتمر مختلف هيعرض لنا على مدار 30 يوم أكتر من 100 محاضرة ل 100 محاضر مختلف. مؤتمر دولي بيشارك فيه 6 دول عربية بنخبة متميزة جدا من المحاضرين العرب. بيشارك في المؤتمر طبعا عدد كبير جدا من السادة الأفاضل أطباء الأسنان من داخل جمهورية مصر العربية وخارجها، السادة الأفاضل أساتذة الجامعات المصرية الحكومية والخاصة. كل المشاركين وكل المحاضرين معانا في المؤتمر بيحاولوا انهم يقدموا كل ما هو جديد وكل ما هو متميز ومختلف في مختلف قطاعات ومجالات طب الأسنان. المؤتمر اهتم بكل التخصصات طب الأسنان زي الجراحة، التقويم، طب الفم وعلاج اللثة، التشخيص، الاستعاضات، تجميل الأسنان والهوليود سمايل وغيرها من التخصصات الحديثة اللي بقى كتير من أطباء الأسنان مهتمين بيها جدا ومهتمين إنهم يكتسبوا خبراتها ويتعلموها.
السلام عليكم ورحمة الله. معاكم أستاذ دكتور هالة هزاع، أستاذ طب الفم وعلاج اللثة والتشخيص، كلية طب الفم والأسنان جامعة الأزهر. وحاليا أنا رئيس قسم طب الفم وعلاج اللثة والتشخيص والأشعة بجامعة الدلتا. بتشرف كمان بكوني السكرتير العام لآيدك، المؤتمر اللي بتنظمه EDS. EDS للي ما يعرفهاش هو اختصار للإيجيبشن دنتال الإيجيبشن أسوسيشن أوف دنتال ستودنتس أو اتحاد طلاب أسنان مصر. الجمعية طبعا بقى لها كذا سنة شغالة وليها فروع في جميع كليات طب الفم والأسنان بكل الجامعات. النشاط بتاعنا بيبقى مخصص أو موجه للطلاب وللخريجين من أطباء الأسنان. نشاط علمي بيتنظم بشكل دوري، كل سنة ليهم أكتر من إيفنت، بالإضافة لبعض الأنشطة الاجتماعية والدورات التدريبية كمان. الحقيقة هم السنة دي بينظموا هذا المؤتمر اللي بيبقى أونلاين، وإن شاء الله هيبدأ يوم 23 أغسطس، ومنظم لكم فيه عدد كبير من المحاضرات، سبيكرز من ناشونال وانترناشونال، فيجرز كل واحد في مجاله. كل اللي انت محتاج تعرفه في الادفانسد دنتستري هتلاقيه في كل الفروع ان شاء الله. فانا بدعوكم جميعا لحضور المؤتمر، وان شاء الله كمان بشجعكم، هيبقى في مسابقات وفي سحب في وقت كل محاضره هيبقى شغال، وكمان في سحب كل اسبوع على اجهزه مفيده جدا ليكم، الايبكس لوكيتور في عندنا سحب عليهم. ان شاء الله المؤتمر ممتد على مدى 4 أسابيع، كل اسبوع فيه 3 ايام، من يوم الثلاث والاربع ويوم الجمعه، يبقى انا عندي 3 ايام كل اسبوع، وبادئين تقريبا من الساعه 4 للساعه 10. ان شاء الله تتبسطوا معانا، وان شاء الله نلقاكم دايما على خير. ميرسي لحضراتكم.
Okay, hello everyone. I'm Dr. NDAYISHIMIYE Samuel, a practicing dental surgeon at Rwanda Military Hospital. Today we are going to share about emergency management of oral and maxillofacial trauma, including prophylactic antibiotherapy. So in our daily duties, our daily practice, we dental surgeons or dental students or whatever was the medical practitioner receives a patient of trauma, and for us, oral physician, we are concerned about oral and maxillofacial region. So we are going to look how we will handle those patients. So we are going to see, these are my outlines, and on introduction, so we are going to see introduction, and we will see a theology of oral and maxillofacial traumas, and we will see how we can assess patient with oral maxillofacial trauma, and we will see in the classifications of oral and maxillofacial trauma, where we will see that there is soft tissue trauma and hard tissue trauma. In hard tissue traumas, we often see people with mid-face, mandible, and dental traumas. So we are going to see each in details. Then we will see the complications that arises when we do not manage well the patient with oral and maxillofacial traumas. And then we'll see about antibiotherapy, where we will conclude with prophylaxis, prophylactic, when to give prophylactic antibiotics or when not, and which combination or which drugs are we going to use in our prophylactic treatment. So as introduction, we are going to discuss about trauma patient. First of all, what's trauma? What's tissue trauma? So tissue trauma is when the tissue is damaged by either physical, chemical, or a thermal agent or mechanical. So we do say that a maxillofacial trauma is an emergency when it's compromising airway, so the patient is not able to breathe, or there is a brain injury, he's in comatose or he's unconscious, there is a C-spine injury, or there is an aversion of tissue where the patient are at risk of getting severe infections and also blood loss. Also, when it's restored, it will lead to aesthetic compromise. So, oral and maxillofacial region is a crucial area that serves as airway, aesthetics, and masticatory, as well as helps in speech. So, facial injuries, we need to pay attention on facial injuries with great care, because their complications are high due to the nature of the wounds there, and also aesthetic significance of those wounds. Also, the facial traumas are life-threatening, because when someone is injured, or most of the time, due to airway obstruction, secondary to bleeding or infection, or edema, which follows any trauma. Also, injury that are in maxillofacial region, they are from motor vehicle accidents, fire sports, fights, and domestic violence is quite high, because when someone is on assault, the first region to be exposed is the head, and the one to be beaten or stricken is the oral and maxillofacial region. Facial trauma is the amongst cause of the maxillofacial emergence, of course, because it leads to bleeding, and also it compromises the airway of the patients. So, and most of the time it's associated with life-threatening injuries like head injury, brain, and also the C-spine, and even the extremities, without excluding the chest. So, the causes of oral and maxillofacial trauma also, we see cases from the work when people falls from the work accidents and bicycles, assaults. It's prevalent here. They are cut with machetes and beaten. Also, the sports, and in others, we can the other causes of oral and maxillofacial traumas. So we classify oral and maxillofacial injuries in soft tissue and hard tissues. In soft tissues, we see abrasions, contusion, ecchymosis, laceration, and avulsion of tissues. While in hard tissues, we see the fractures of upper face, like orbits, supraorbital region, and we see mid face, the maxilla and the zygoma, and also we see the lower face mandible. We see the displacement, like the nose displaced, or the joints is displaced and dislocated, and we can see also the dental alveolar injuries where the teeth and the alveolar bone are injured. So when we see in our daily duties, or we are called to receive a patient that is in critical conditions, most of the time we see the patient while the first aid is done, like those who are working in tertiary hospitals, in referral hospitals, but those who are in district hospitals, and some who are working on health center, on health centers, they are the one to do the first management of those patients, and that's why it's crucial to have this knowledge of how we will approach patient with this kind of severe injury, which is life-threatening. So first of all, in mass casualties or people in mass, they like in accidents, we do triage. This is the first things we select patients who are at risk of die, or we can see how we can arrange according to the resources, how we can help people. So then we do primary survey, resuscitation if possible. It's mandatory to do resuscitation for sure. If someone in the primary survey is in a severe injury, that can lead to death. And then we can do adjustment on primary survey. We can adjust the treatment according to is recovering or is not recovering. We can change, or we can maintain it, or we can stop once he is recovered. Then we go for secondary survey. Primary survey is done according to ABCDE. This is an abbreviation. We usually use A stands for airway, B for breathing, C for secretion, and D and E for exposure. Then we do secondary survey. Sorry. Where we do a history like, and we see the patient as who will see, maybe he's recovering. We kindly approach the patient as a whole, where we see, is he taking any medication? Is he having any medical disease, any current disease that can compromise the treatment? Or is he able to, has he taken the meal, or so that we can approach as patient as a whole. So at emergency, we do triage. We see the patient who are more critical, and we do primary survey, which is the A, B, C, D, as I mentioned, and E. Airway and the C-spine protection, if it comes at the first priority, then we do assessment of breathing and ventilation. If the patient is able to breathe or not, then we can do mechanical ventilation, or we assist him to breathe. Then we see the circulation. Is he having the good pulse, or pulse is there or not? Is he having an hemorrhage? Do we see any bleeding somewhere? So we stop the bleeding. Then we see this disability. Here we assess the GCS, Glasgow Coma Scale. Is he alert? Is he awake? Or he's not responding? He has sensation somewhere. He lost sensation. He's able to move or not? Then we do exposure. We see the environment. Then after this, we can anticipate. If you see the airway is compromised, so someone is not able to breathe. If you call him, he cannot respond. So you conclude that he is not able, and when you conclude that, you have to anticipate, of course. So then secondary survey, as I mentioned, we do a head-to-toe examination. Then we see RH medication on which patient is on. Then we see the past illness, including the pregnancy. Okay. Then we see the last meal. Maybe someone is need of general anesthesia, and this is going to compromise when the patient took his or her last meal. Or also, it can be in fasting and he's in coma, or he's having hypoglycemia. Then we ask about the event. So on airway, we call the patient, and if not responding, then the airway is compromised. So we have to inspect for any foreign body in the oral or pharyngeal region. So that can compromise the breathing of the patient. At that time, you use your suction. You remove all the clots in the oral cavity, and also the secretions. Then there are maneuvers to open the airways. This for sure you all know from the basic life support, jaw thrust and chin lift maneuvers to open the airways. So if the patient is unconscious and he cannot breathe well, oral tracheal intubation is advised. So we do this gently, so because we do not know the status of the C-spine. So the patient might have the C-spine. After you maintaining the airway, then you will put a C-collar for the patient to protect the C-spine. Then we will assess the ventilation and the breathing. Is the patient his chest rising or during inspiration, or he's not? Then you use your, if you have a pulse oximeter, you see the oxygen saturation, hemoglobin saturation, and if it's below 90, you conclude the patient is not well, patient breathing is not well. Then we see what's causing the patient not to breathe. So sometimes in trauma patient, there is what we call tension pneumothorax. This is the air to go into the pleural cavity, and then the patient is not to inspire. Also, the patient can have massive hemothorax. He had the trauma on the chest, and much blood has gone into the pleural cavity, or he has an open wound on the chest that is causing open pneumothorax, or sometimes they have trachea or laryngeal injury. So these are among the causes that prevent patient to breathe well. In this time, you will give for sure the supplemental oxygen via the cannula or the mask. Then if you see the patient is having tension pneumothorax, how you can conclude that? You will do percussion of the chest, and then it will be very resonant. So you do needle the compression, and then you save the patient that time. Because this tension pneumothorax, it affects both respiratory and circulatory system. So you can have a patient with who is not breathing, and also whom his heart is not beating due to the tension pneumothorax. On circulation, we assess for cardiac output, and if there is any bleeding, we stop the bleeding. So, as I mentioned, there are three elements to assess cardiac output. The first is the level of consciousness. You will assess the patient if he is stable, or his physical status or mental status is altered, he's confused. So it can, among the cause of altered mental status, it's hypoperfusion of the brain. Then you will see the skin perfusion, like someone who has lost much blood, he will have the cold extremities and the facial, and the skin will be pale. And also you will assess the pulse. Radio pulse is the one we usually assess, but if it's absent, because on trauma patient they might lose the much blood, and then the radio pulse can be missing, or tibial pulse. Then we will assess for central pulse at the carotid or the femoral. If those ones are missing, like femoral one, bilaterally, this is an emergency. You have to do a resuscitation. Then external bleeding has to be controlled and stopped by direct pressure. So you will put a compress on the breathing area, and you compress it. If it's on extremity and the compressing is not enough, the tourniquet may be applied, but this is associated with the risk of causing the gangrenous. Then major area of bleeding, these are assessed via radiographic imaging, like chest, abdomen, and the periphery. But also long bones like femur, they bleed too much once they are injured. So we do chest X-ray, peripheral X-ray, and forecast assessment with sonography for trauma. This is, you know, in the abbreviation of FAST, so that we exclude any internal bleeding to the patient. So if it's there, then we have to anticipate this is an emergency. So we do replacement of intravascular volume with the IV fluids and blood. So on disability, we see GCS as I mentioned, and then we will see the papillary size and reaction. We will determine the spinal cord injury if it's there. Then we will see if there is any decrease in the level of consciousness, and this may indicate brain hypoxia, hypoperfusion, hypoglycemia, or direct trauma to the brain. So adequate oxygenation is mandatory so that we can prevent the secondary brain injury. So the primary brain injury is due to the direct trauma to the brain, but once the brain is not injured primarily, it can go to an injury secondary to those factors I mentioned above, like hypoxia and the hypoperfusion. So then we do exposure. We remove garments for thorough examination to see if there is any other injury on the body. If this is done, then we will cover the patient to prevent the hypothermia, which is also very bad in trauma patients. It kills people. And we make sure the IV fluids we are giving during resuscitation are warmed up to the body temperature, because if you pull them and you give much of them, this will expose our patient also to the hypothermia. So secondary survey, we do head to toe examination, and then we see the patient. If he is allergic or she's allergic to any drug, we ask, and then we can prevent allergic reaction. Then we see the patient, we see the medication on which patient is taking. So then we see if they can interfere with our treatments, or like someone who is taking anticoagulants and he's injured. So you will have troubles in hemostasis. So you need to know all this information, because you can struggle with hemorrhage while the patient is taking anticoagulants. Then you see the past illness. Someone is having like episodes of any illness, like hypertension, kidney disease, or like malaria, which is endemic in East Africa. So people with the malaria episodes, they tend to have low level of hemoglobin. So you will have to, or is malnourished. Then you assess, you ask if the time of his last meal, because of meal in significance of the anesthesia, with the general anesthesia, also with hypoglycemia. Then we do exposure, we assess the patient as well, we look on the back, we look on the front, and then we conclude. Then we ask the thorough history about what happened to him or her. So this history of event may help us in the conclusion of what extent do we assume the patient has injured. So also this will guide us in the management. So if like someone is falling from a height of 6 meters and the head has fallen on the stone, or he has fallen on his neck, or what you ask, you can suspect to have a spine injury or a head injury as such on event history. So we assessment of a patient, we assess, we ask about the mechanism of injury, and also we do examination which is quick and proper. In the maxillofacial area, you approach airway circulation. You have to be quick, because if you are not quick, then someone is having like maxillofacial area trauma, which will obstruct his airway. you will lose the patient while you are circling around. Then begin overall inspection and any facial symmetry. You do a neurological examination of all 12 cranial nerves. Then you assess the sensory nerves of the face, head and neck. Because in middle face injuries, sometimes people are having paresthesia infraorbital, or the trauma can affect the facial nerve. You see the peripheral, or it might have a Yes, doctor. Hello. Sorry for disruption. Then we look on facial symmetry, if it's asymmetric or not. Intraorally, we see the occlusion if disturbed or conserved. We assess for step deformity. We see for the periorbital ecchymosis, palatal and sublingual hematoma. CS, if there is any CSF leakage, then we note the respiratory pattern and we assess. We assess his spine dermatomes. So on soft tissue injuries, what we mostly see, we see the lacerations, but we do have also abrasion, which that's due to the friction between objects and the soft tissue of the face. You will see that the epidermis is mostly involved, but sometimes the deeper areas like dermis and the muscles are involved, and this will be painful, of course. Then on management, we clean and irrigate with saline. We remove any foreign body if it's there, and we give patient topical antibiotics like tetracycline ointment is the one we usually use. Then secondly, we see confusion. This is due to the blow of or fall against a hard or blunt object. So you will see the blood collected under the subcutaneous or submucosa area, and it will seems like it's bruised. So if it's there, we have to assess if there is any bone trauma. So this is managed by ice packing because hematoma is going to resolve for sure, and we have to prevent further edema to that region, and it's prevented by ice pack. Then we will see the hematoma, which is the localized collection of blood in subcutaneous or intramuscular or submucosal area. Sometimes, but can say most of the time it's really absorbed, but like sometimes it persists and requires incision and drainage. Or if it's left there, you have to cover the patient with antibiotics because sometimes it gets infected and cause troubles. So lastly, on soft tissue, we see lacerated or aversive wounds. They are most frequently encountered in maxillofacial area because of the exposed head and face tissues, face area. So motor vehicle or vehicle accidents, or where low vehicle missiles or bombs, they jump and they go there. They are the targeted areas. So contused tissues, muscles, and lacerated are found there. So you can find them devitalized, so you can do the debridement. So laceration have to be sutured as well as you can, because this will help in aesthetics and the prevention of infection. Many literatures suggest to suture them before 6 hours, but it can be go to 24 hours. Also, you remember to suture layer by layer. Most of the time, what I saw, people suture the skin, but if it's a through and through wound, they will forget to suture mucosa and forget to suture the muscles. That time, the infection will come from the oral cavity and the sutures will be infected. Then the patient will require again the debridement and also resuturing. You do the debridement and irrigation. Sometimes if it's just a laceration, we do open dressing with tetracycline ointment. Prophylactic antibiotics can be have to be given. What I saw, most of the people, what we receive, they are giving chlorhexidine, and we are going to see how weak is chlorhexidine into the wounds of that involves the oral cavity. Then we give mouthwashes. What we have to keep in mind, the wound that we are communicating with the oral cavity, they are never clean. Oral cavity is a polymicrobial, have more than 700 species of bacteria. So this wound is not clean. Also, we see penetrating wound or punctured wound. So they are caused by pinpointed object like knife, bullets, or bomb splinters. So we do careful examination, and also we ask CT scan. We request a CT scan to see how hard tissue are then. Also, we can't exclude the gunshot injuries. They are classified as as unique because they require special management and they are aggressive in nature. So they are complicated in management. So once you see them, whether it's small or it's big, it requires special attention. So on hard tissue, we do see people with mid-face fractures like RE41, which is detached maxillary alveolar process. And for sure, the alveolar bone will be mobile. To assess it, you hold with your left hand on the tip of the nose, and then you shake the alveolar process. You will see the alveolar bone and the teeth are mobile anteroposteriorly. Then there is RE42, which is called also pyramidal. This is in short term detached maxilla. So the whole maxilla from the nasofrontal suture is detached, and this will have infraorbital ecchymosis. Sorry. Also, the finding or those ecchymosis on infraorbital area gives this fracture a panda face, like someone is looking like a panda. If it's an animal with a black eyes. Then we have Re43, which is a transverse fracture through the face. Otherwise, the whole face is detached from the cranial cavity, and it's called craniofacial disjunction. So this is very dangerous. Re42 and Re43, they can lead to they can, when you are assessing them, you can see patient with having CSF leakage through his nose or her nose. So their complications, they are airway compromise. Also, those patients can have ascending meningitis. Also, they can have a cavernous thrombosis, as these fractures involve the danger triangle of the face. So the management is ORIF. So what do we see when we are assessing a patient with the hard tissue or fractures of the face? So we receive facial ecchymosis. People will have tenderness on those ecchymosis area or non-ecchymosis area. If there is any deep fracture, you will see, like in some cases, you will see disturbed the ocular movement, and the patient, some muscles of the eye are interrupted into the fracture, and you will feel you will feel step deformities around the face in the prominent area, like on the zygoma area or like on the mandible area. You will feel there is a step deformity. You will see also rhinorrhea, which is CSF leak through the nose, and otorrhea, which is CSF leakage from the ear. You have to assess them very well, because you have to differentiate them from a flu. This rhinorrhea from through discharge, called the flu. And intraorally, you will see the patient has anterior open bite and malocclusions. Sometimes they have the palatal fracture, and you will see the palatal ecchymosis. So these injuries are usually associated with head injury, which is traumatic brain injury, like C-spine or chest and extremities. Sometimes they are involved. So how do we approach? We approach them through 8 years, as I mentioned first, and then after stabilizing the patient, you will give the antibiotics, painkillers, and also mouthwash. Those are the investigations that we have to look for, because those patients may not need the emergency surgery. Sorry. So we need the full blood count, renal, like renal function, like urea and creatinine. We need the liver function. Because of the breathing, those people might have renal injury or liver injury. You will see them with liver injury, liver enzymes elevated. Also, we ask we ask a CT scan without contrast to see the bone, the hard tissue status. Then we go for the lower facial fractures. When we say lower facial, If you can see well on this image, this is the mandible fractured in anterior portion. Here there is a fracture. On this diagram, it's showing how the fracture in the anterior, like parasymphysial region, is pulled posteriorly to block the oropharynx and laryngopharynx. So with the tongue, these patients are at risk of getting airway obstruction because of displacement of that mandible. Also on the midface, when the midface is fractured, the direction of the fractured segment is downward and posterior. So they block the oropharynx and the nasopharynx. So the patient is not able to breathe through the nose, but with the intraoral he can. But make sure that the mandible is not fractured. If even the mandible is fractured, this patient or airway is totally compromised, and they need to have surgical prepared or intubation. So on mandible fractures, people will have the swelling on the site. They will have trismus, sublingual hematoma, and also we will see malocclusions. Most of the time, people will complain their teeth are not closing, and on palpation, we will see staple deformities. Investigation we do OPGP of the scar or lateral view, but also CT scan is more helpful to see the condyles and the overall mandible. So they are classified like symphysial, parasymphysial, ramus, and condylar fractures. These ones you know, but are not what I'm going to talk much about. So this point here, bilateral parasymphysia or body of mandible fractures have downward and posterior displacement due to the hyoid muscles. This will cause the airway blockage. So those people with parasymphysial fractures, they are at risk of getting airway compromission. Again, treatment, you will give this patient, you will make sure the airway is patent, and also dexamethasone is usually used for reducing the inflammation because of those muscles. Like if the hyoid muscles are inflamed and the muscle of the tongue, when they are traumatized, they get edematous, and also with displacement of the fracture, they will contribute much to the airway obstruction of the patient. So most of the clinicians, they prefer to give this intramuscular steroid to prevent that much bleeding, and then afterwards they will give prophylactic antibiotics, painkillers, and mouthwashes. So you have to advise the patient not to lie flat in a supine position, because this will favor gravitation and the muscles to pull the fractured segment to go posterior and block their airways. So the permanent management is through, we can do maxillomandibular fixation or we can do ORIF. So we come to dental-alveolar fractures. We often read dental practitioners, they receive most of these patients with dental-alveolar fractures. So like you will see avulsed teeth, you will see subluxated teeth, you will see crown fractured or root fractured, and also you will see the dental-alveolar fractures. So it's up to you to know is what to do. So here on avulsed teeth, first of all, where we are practicing, most of people, they do not know that avulsed tooth can be implanted, and then it get like endodontic treatment, and they get get fully function as the normal tooth. So they throw the teeth, and when you arrive at the emergency, because sometimes we are on call, you will see patient, they will tell you that their teeth are thrown. So you have to advise the clinician that are working at the emergency that those teeth are not be thrown. So they have to be kept in milk. There is what we call hands balanced solution, and milk also can work. And then once the dentist is available, he will implant the tooth, and will give prophylactic pain management, prophylactic antibiotics, mouthwash. Then that tooth it has to be fixed for sure for 3 weeks, so that it can get in fully functioning. Then we will see subluxation injuries. Those teeth are immobile, or they are not in the anatomical location. So you have to you reduce them in their normal location, and then you will give prophylactic antibiotics. Split them, of course. Crown fractures, you just keep the pulp or the dentin with calcium hydroxide. Then the patient has to wait for permanent. If it's built up, if it's a root canal treatment that it has to be done, you will conclude after. Then on the interalveolar fractures, you will see a segment of teeth are fractured, or they are here in this picture. You see there's a lower central and lateral incisors are both fractured, and they are like avarized, but for sure lingo gum is holding them. So you reduce them, you put them in their anatomical location, then you suture back the soft tissue. If you can look very well on this lower picture, you can see that the dentist has done interdental wiring. These teeth are fixed with the interdental wiring. So if they are going to be held there for 4 to 6 weeks, and then root canal treatment, or if they are non-vital, root canal treatment can be done after 3 to 6 weeks, or according to the assessment. So complication of oral and maxillofacial trauma, we classify them as early and immediate, intermediate, and late complications. So on early and intermediate complication, patients will suffer airway obstruction, and you have to be sure that you prevent this, because you can anticipate on these immediate and early complications for sure. They will have bleeding, they can have nerve injuries, they will have pain, swelling, malocclusion. People may bleed up to the extent that they have shock and finally die. Intermediate, so this takes like days to happen, like trismus infection, sepsis, infective endocarditis, meningitis, cavernous thrombosis, facial space infection. Also, these can lead to the death. Okay, they are preventable by our acts. So how we anticipate first? If you do not anticipate, if you do not prevent them, give proper antibiotics, prophylactic antibiotics. The patients are exposed to these intermediate complications. So this is the role of the dental practitioners, where they have to anticipate. So they have to prevent these intermediate complications and late complications. Late complications includes osteomyelitis, facial deformity. How do oral physicians prevent facial deformities? So like in soft tissue traumas, you have to be sure that you sutured very well, because the aim of suturing the tissues is to improve or to fasten the primary healing. So if you do not cross layer by layer, then the wound will have dehiscences, which will lead to the scar contracture, or the patient will heal by secondary tension, which will lead to these deformities. People with fractures which are not treated, they will have with microchronic tissue traumas will lead to the scars. Then people with trauma, like in other traumas, they have post-traumatic stress disorder. This is psychological complications that develops after the healing of the primary injury. People will have this PTSD. Also, people with mandible fracture on the condyle, because sometimes they do not notice that they had that fracture. Once it's not open, or it's there is a mild derangement in occlusion, they can tolerate. They will think it's normal, but after sometimes they will develop TMG ankylosis, temporomandibular ankylosis. So, prophylactic antibiotherapy. So, to give antibiotics, you need to know how the antibiotics works. So, antibiotics work by cell wall. They are what we call cell wall active agent or cell wall inhibitor. They prevent bacteria to form this outer wall. So then, via osmosis, the molecules will enter inside, and then they will burst after, or they can destroy the cell membrane. Then they go inside, enable other drugs that works on the DNA or on the protein synthesis to work effectively. So they are what we call cell wall active agents, like penicillins, cephalosporins, carbapenems, and monobactams, even vancomycin and bacitracin. They are cell wall inhibitors. They are what we call protein synthesis inhibitors. They prevent the bacteria to synthesize the proteins, and then they are not able to grow and to divide. So by that, the pathogenicity is reduced, and then our normal immune system will phagocytize what is left there. Then there is what we call DNA synthesis inhibitors. They act by preventing, by inhibiting DNA GRAS and RNA polymerase. So if the bacteria cannot synthesize or duplicate its DNA, then its division is not possible. Then work is done. So I picked the group that we usually use, because 90% of the people who receive the prophylactic antibiotics, they receive, we are giving penicillin. So I just put this slide to make sure that when you are prescribing a penicillin, you know where it's going to act. You know the bacteria that you are fighting with, and then when it's not working, you will for sure notice where is the error, and you will anticipate by changing it. Because sometimes when we are assessing the wound, you will do the debridement, you do washouts, and then you suture the wound, or you do a packing. But after 1 day or 2 days, given antibiotics, you will see the same outcome. You will see the wound is not getting proper. It's still that pus is still coming. You please check where on your antibiotic regimen you gave, or the nutrition status of the patient. Because on hearing, this matters a lot. So on penicillins, we have what we call natural penicillins. Those are the ones that are invented the first, where we have penicillin G and penicillin V. Penicillin G, it's given parenterally, while penicillin V, it's given orally. So they are effective for gram-positive cocks and bacilli, and few gram-negative. And of course, this sprocket treponema pallidum that we usually face when someone is having oral syphilis. So we give penicillin shot, penicillin G shot to clear it. But these are not effective against gram-negative bacilli. So they are used as prophylactic antibiotics for rheumatoid fever in children who suffers pharyngitis, because 3% of those who are suffering from pharyngitis, it's assumed to develop rheumatoid fever, rheumatoid heart disease. So that's why they prefer to give them this penicillin as a prophylactic antibiotics. Also, they are given on mixed oral infections, like those with aerobic and anaerobic, like acute abscesses, those which are very small and they are acute, you can give them, it works. But on late stage, like it's a chronic one or it's a very big one, we are sure, or I saw people who presented about the genic infection. In early stage, they are aerobic most of the time and facultatives. So if it's in late stage, they will develop, they will be contaminated with anaerobes, which will not favor our natural penicillins to work. Then we have also what we call anti-staphylococcal penicillins, like methicillins, nafcillin, cloxacillin, and the dicloxacillin. These ones are given for anti-staphylococcus purpose, like someone who is having a skin injury, a skin trauma. So they do give cloxacillin for prevention of contamination with Staphylococcus epidermis, because this is very sensitive. Cloxacillin is very sensitive. But on intraoral wounds, you are failed, because oral cavity is not having only Staphylococcus. It has other many microbes, which are aerobes and anaerobes, that you have to take care of. Then you have wide spectrum that we do use, because of they help us a lot in fighting against gram-positive and gram-negative bacteria. We have ampicillin, which is very good in respiratory tract disease, like in pneumonia, and amoxicillin, of course, which we do use for dental and oral infections prevention, and also urinary tract infections. So they are good because they help in gram-positive, gram-negative. They also include Enterococci, Haemophilus influenza, E. coli, Listeria monostaginus, Proteus, and Salmonella. So these ones also, they are given because of the resistance. The bacteria develop the resistance. What we call they produce what we call beta lactamase enzyme. So they are given beta lactamase inhibitors, like clavulanic acid, sulbactam, and tazobactam. So the combination we use with this beta lactamase inhibitors is augmentin, which is amoxicillin with clavulanic acid, and the unacin with which is ampicillin combined with sulbactam. Also, we have what we call anti-pseudomonas penicillins. These are made for Pseudomonas infection, Pseudomonas aeruginosa infection. This is acquired. This is the hospital acquired infection that was very tricky, and it was fatal for sure. So they developed this penicillin to work on them because it was resistant to other penicillins that were used at that time. So they are piperacillin, ticarcillin, carbenicillin, and also they are given anti-beta-lactamases like what we see. Zosine is piperacillin with tazobactam, and timentin, which is ticarcillin combined with clavulanic acid. So clinical feature for this is Pseudomonas infection is green pus. So you open the wound, you will see pus which is green in color. Then you will notice this is not a normal pus from Staphylococcus infection, or this is for sure a Pseudomonas infection. Then you will give those anti-Pseudomonas penicillins. Those are the most prescription people use, and sometimes they are combined. So we use amoxicillin 30 to 50 milligram per kg most of the time. And then if it's only on the skin, or it's somewhere you're not contacting the oropharyngeal or digestive tract, we can give cloxacillin 30 to 50 milligram per kg. If the infection is, you are suspecting someone to be infected with anaerobe, you combine amoxicillin with metronidazole. If you need for IV antibiotics, we do give ceftriaxone 30 milligram per kg. This is given in BID twice a day. Also, sometimes you see infection is resistant, you give gentamicin to fasten the action of ceftriaxone. They will give a potentiation. So, in summary, antibiotics that we are giving, we give penicillins for prophylaxis, and if our patients are allergic to penicillin, clindamycin can be given, vancomycin is given for Staphylococcus resistance, methicillin resistance. Staphylococcus infection, methicillin is given, vancomycin is given. We can give macrolides like erythromycin, though its potency into the oral cavity infection is less. We do give tetracycline, like when we are treating periodontal diseases. We use doxycycline. It works very well because it's a very broad spectrum tetracycline. Cephalosporins also, they are used. Those are the ceftriaxone, cefotaxime. There are many classes that we use, but they help as penicillin. They have the same work. Even the allergic, someone who is allergic to penicillin is not allowed to be given a cephalosporin. So antifungal, we usually give this antifungal infection when we are suspecting someone to have oral candidiasis. So we give like nystatin lozenge for treatment of oral candidiasis. So thank you for your kind attention. I think this is the end of my presentation. Additional to this, we do give mouthwashes like Rexidine, Chlorhexidine, Betadine, for the prevention of infection locally. So I didn't include that slide, but it's very crucial because our patients sometimes they not able to open their mouth and they cannot do a thorough oral hygiene. So you have to give mouthwash at least, or when they are hospitalized, they are intubated, you do mouth oral toileting with those mouthwash. This will save you a lot. They will prevent infection from the oral cavity to spread, and also they will prevent the bacteria to grow into the oral cavity. So these are my references. I used those books. So if you need further information, details, you will consult them. You will gain a lot from them. So thank you so much. If you have any question, you are welcome to ask. Okay, thank you so much. This is the end of the presentation. You have a nice evening.